You're listening to Medscape's In Discussion series on hidradenitis suppurativa, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Drs Okoye. Dr. Okoye is professor and chair of dermatology at Howard University College of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Drs Okoye. Welcome to Medscape's In Discussion podcast series on hidradenitis suppurativa. Today, we'll discuss insulin resistance in HS with our guest, Dr. Drs Bordone. Dr. Bordone is a board-certified dermatologist and assistant professor of dermatology at Columbia University Irving Medical Center. Dr. Bordone specializes in complex medical dermatology, particularly in autoimmune skin diseases. Thank you for joining us today, and welcome to the Medscape in Discussion podcast.
Thank you for having me. This is very exciting.
So, I have been looking forward to this conversation for a long time because today we're focusing on one of the major comorbidities of HS, which is metabolic syndrome, in particular insulin resistance. And Dr. Bordone, you have quite a bit of experience evaluating and treating insulin resistance, and you work closely with an endocrinologist. So, this topic is fascinating. I think you might be the US expert on the intersection of insulin resistance and dermatology. And so we cannot wait to learn from you.
Thanks. I hope I live up to it.
So tell me a little bit about your experience with HS.
So with HS patients, I had always thought there was something missing. These patients would come in, they would have terrible inflammation, and nothing seemed to work. Even these biologics that would suppress the inflammation always left them maybe slightly improved, but they still had pretty terrible disease that seemed to me, in some cases, not compatible with the normal life. I started to notice in many of them that they had signs of insulin resistance on their skin, like acanthosis nigricans, which is thickening of the skin, which leaves a dark velvety appearance on the back of the neck and in the armpits. And many patients were overweight, which can happen with autoimmune conditions in general because it's very hard to exercise if you're not feeling comfortable. And I also knew from work in immunology that inflammation causes insulin resistance. But then I started to ask questions about family history of diabetes or a personal history of gestational diabetes. And there seemed to be a really strong trend, which made me start to evaluate their labs. The funny thing is, they all had normal blood sugars for the most part. Their labs looked pretty good. But then if you looked a little bit deeper, there were things that didn't seem quite right. Like their liver enzymes were inverted, meaning the liver enzyme that's typically higher is your AST and it was lower than their ALT. For the layman means your liver isn't behaving like it should, and that's an indicator of insulin resistance. So I just started to notice a trend, and it seemed like an obvious fit. So I reached out to an endocrinologist and we started discussing it, and we put our heads together and started to dig deeper. And then actually I spoke to you, and you really solidified things for me when I met with you and the other person you were doing research with. You guys were talking about neutrophil webs, and there was an overlap between the inflammatory response of the liver in fatty liver and liver disease from metabolic illnesses and HS. I remember it was like years ago now that I spoke about it with you, and I was like, okay, this is it. This has to be it.
That was like a really important day in my career as well because it felt like we both independently were concerned about the fact that people's blood sugars were normal, but they couldn't be. Like something was off.
Yeah.
And so for me, the real epiphany was when you taught me to check for insulin resistance using the appropriate lab. So can you tell us more about how to actually evaluate people for insulin resistance? And it's not the hemoglobin A1C.
Definitely not. I mean, the other unifying trend among all of these HS patients is they have a very hard time losing weight.
Yes.
And they, even if they were diet and exercise, they seem to really hold on to weight. Their sugar looked great, but what I started checking was homeostatic metabolic assessment score, where you check their fasting insulin and fasting sugar between 8 and 9 in the morning. That's usually the best time. Once you get further into the morning, around 10 a.m., your circadian rhythm lowers your insulin. So you want to see it first thing in the morning after you've been fasting for 8 hours. So I tell patients, stop eating at midnight and basically roll out of bed and have your blood drawn. In New York, it's a little bit of a challenge because people walk 20 blocks to a lab. So I have to remind them, like, walking is still exercise. It'll bring your sugar down. But if they had a meal at, like, 8 p.m. and then at 8 a.m., their blood sugar's over 100 and their fasting insulin is high, like they had just eaten a meal, there's something very abnormal about that. And a normal fasting insulin, you want it to be around 5. I had patients coming in with fasting insulins of 40, 60. It's almost universal in the HS patients. They have very high insulin production, and it seems to happen 24 hours a day, whether they're eating or not.
Hmm. And so you mentioned the homeostatic assessment. So that is the HOMA-IR test, HOMA-IR test. And so how is that calculated? Can you tell us a little bit more about that?
So, truth be told, I just punch it into an online calculator, but it just assesses whether or not your insulin is reducing your glucose enough, because for a high insulin, your sugar should be low. But if your glucose, your sugar is high and your insulin's high, then that insulin is not having an effect. But yeah, you check it between 8 and 9 in the morning, no exercise ahead of time. And I tell people, don't lift weights or exercise the night before, because if they want to be, a go-getter and exercise for an hour the night before, your blood sugars are actually good for about 24 hours after. So they can skew the results quite a bit. But this HOMA-IR score, when you're sensitive to your insulin, all patients with a good HOMA-IR score of 1 to 2, sometimes even lower than that, meaning they're very sensitive to their insulin. Once they're above 2, they're insulin resistant. And then I have some patients with a HOMA-IR score that should be under 2, which is instead in them, it's 14. And they're walking around with totally normal blood sugars because they just produce more and more and more insulin to reduce whatever blood sugar they have to a fine level. But that amount of insulin production is so abnormal, it leads to other health issues.
And because that high insulin is keeping their blood sugar normal, it's keeping their hemoglobin A1C relatively normal as well,
Mhm.
which for me was the real epiphany. Testing glucose and hemoglobin A1C is not enough, right? You have to test the fasting glucose, fasting insulin, plug those two numbers into that online calculator, and then really make decisions based on the HOMA-IR score, not hemoglobin A1C.
Yeah, and it's heartbreaking because I think a lot of these patients know there's something wrong with them. They've flown under the radar because their A1C is fine. They don't feel well, but no one gives them an explanation because it hasn't been part of the general workup that a primary care doctor does or dermatology has ever done. But I think that's changing, particularly if it's a young, healthy person that doesn't have high blood pressure or any things that they're aware of, but they see something's going on with their skin, they'll see a dermatologist. So we're the ones that are going to have to identify it and test for it and diagnose it.
I totally agree. So you mentioned when the insulin level's high, people don't feel well. Can you tell us a bit more about that? What are the effects of an elevated insulin level?
This is so interesting to me, and it is so diverse. First, insulin is a growth hormone, so it increases cell division. One of the things we see aside from acanthosis nigricans is you'll start to see thickened earlobes, and people develop what's called a Frank sign, where their earlobe gets so puffy that it almost folds. That soft tissue growth mirrors the soft palate at the back of the throat. So your soft tissue grows, and as that grows, it starts to obstruct your breathing when you sleep at night, and that relaxes and you're laying back and your muscles in your throat have relaxed, and people develop obstructive sleep apnea. So they always feel tired. The problem with having high insulin is there are times when you haven't eaten for a while and your insulin finally starts to go down. And then for whatever reason, your body starts listening to it in that moment. And then you become hypoglycemic and your sugars get too low. And then you feel tired and woozy. So their sugars can go up and they can go very low too. And it makes it even more of a challenge to lose weight. So they're often fatigued. They have these weird symptoms where they just don't feel right when their sugars get low, and they cannot lose weight, and they get depressed because they are counting I think you said it best. They're counting micro and macronutrients and keeping track of everything, and nothing works. And they're told, just try harder. The opposite of what they need to hear, because then they think, like, well, what the hell else am I going to do? Right. Most of the time, they don't even realize, because it's such a slow creep into insulin resistance, how bad they do feel. But then when you treat them for it, they feel so much better, and their fatigue improves, their energy levels increase, weight starts melting off. Just generally, they can think more clearly. They don't have food noise anymore. There's just so many things that insulin influences.
You mentioned food noise. Like insulin makes you hungry.
It's good to have a lot of insulin in a famine, because you're always seeking out food, and then you're storing it as fat very quickly so you can get
Mhm.
hungry again, because your sugar can actually get low. So it's great in the right setting, but we evolved for so many years to have that, and now we don't really need it. So when people are just producing it all the time and they have access to food, it takes on a life of its own and spirals.
Mm, wow. So, based on that, it sounds like we need to address insulin resistance in any of our patients who present with signs of insulin resistance, but certainly in our patients with HS in whom weight loss can help decrease friction in their intertriginous areas, and weight loss can actually help them be more sensitive to our anti-inflammatory medications, just milligram per kilogram wise. So if only to help our patients in that weight loss journey, just to help them feel better, I feel like we need to think about how do we as dermatologists treat insulin resistance. And I know that you do this all the time. So can you give us some tips?
I absolutely love the GLP-1s. I mean, that's probably my
Mm.
go-to medication. The thing that I first ask patients about is their dietary habits. I think some people really start craving sugar because that's what insulin does to the satiety circuits in your brain. It makes you crave sugar. I often discuss with them what they're eating, and if they're having any drinkable calories or things that dissolve very quickly. Like, I'll tell patients, if you take a bucket of water and throw cereal in, it turns into mush in 2 seconds. So anything that just disintegrates and becomes sugar almost instantly, that is not your friend. We go through some dietary counseling, but exercise is something we discuss. And a lot of times, because they're in such a sad mental state because they've tried so hard and they failed for so long, I go right to using medication. It's almost cruel to ask them to just keep trying without giving them a boost. And some patients say, I don't really want to be on medication, but I say, look, let's just get the ball rolling. We can always take you off of it. You're never handcuffed to anything, but I'd rather see you in a healthy place and have you struggle for another 5 years like you've already been doing.
So tell me, how do you use the GLP ones? Do you do any screening tests? What doses are you using?
Yeah, so I start off with checking, obviously, like a HOMA-IR score. I often check for, especially my HS patients, there's a very high burden of fatty liver. So I do check liver enzymes, and I'll check lipids to see if they have high triglycerides. They often have high triglycerides, low HDL, and a high LDL. And also because vitamin D is fat soluble, their vitamin D is always low. So I'll check all of those and just confirm and show them, yes, in fact, you do have insulin resistance, and you have abnormal cholesterol readings and liver abnormalities. If their liver abnormalities are significant, I also do what's called a FIB4 score, and I'll screen them for fatty liver and fibrosis. And if it's high enough, I'll get a liver scan and send them to GI. I almost always, if someone has liver issues, will start them off with tirzepatide, since the data on tirzepatide for fatty liver is so far the superior drug. So I start them on 2.5 of tirzepatide. I really like semaglutide, but the nausea seems to be a limiting factor. And the weight loss with tirzepatide is double. So if insurance will cover it, I almost always start with tirzepatide, 2.5 milligrams.
Mhm. And you mentioned the FIB4 score. So that's a score for liver fibrosis. And so in order to calculate the FIB4 score, just in an online calculator, it's the AST, ALT, platelets,
Platelets and age, yeah,
and age. Okay.
yeah.
And you're finding patients with HS with elevated FIB4 scores?
Yes, the younger ones tend to be okay, but when you have someone who has really high liver enzymes and lower platelets, it's an issue. I've definitely been surprised by how many people have abnormal FIB4 scores. That has been eye-opening, and they're not getting screened. I wouldn't say it happens all that frequently, but it's much more frequent than what I expected. I thought that maybe once in a blue moon I would see it, and it's more than that. To the point where I have to warn them about taking certain medications that are metabolized through the liver, and I get them into CGI as soon as possible, and it definitely solidifies the need for tirzepatide because of the data showing it helps so much with fatty liver.
And when you have these data, the FIB4 score, the AST, ALT inversion, the HOMA-IR score, does that help with insurance coverage of the GLP-1 agonist?
No. It's like that's actually been really frustrating. I will say that this year, more insurance companies are starting to cover it, I think because they're seeing the cost savings.
Sure.
Yeah, patients are hospitalized less, they wind up having fewer doctor's visits. I don't have patients with HS coming in with flares every other minute. Their HS definitely gets better, but normally, you have to make a good case for either sleep apnea or sometimes I'll have them wear a continuous glucose monitor and show that, yes, their A1C is not high, but their blood sugars do get high, and I will diagnose them with type 2 diabetes under different criteria or enlist the help of an endocrinologist. I do appeal letters, but insurance can be very difficult.
Mhm. Yes, I think that's the major barrier at this point for these drugs that work so well. Do you use metformin?
I do. I use metformin quite a bit. Metformin is great. It's been around for a very long time. And overall, it's very expensive, accessible. The stomach upset can be a problem. So I almost never now use the immediate release. I use the extended release versions. It can help quite a bit, but I don't see it do as much as the GLP-1s. So if I can get someone on a GLP-1, that's definitely my preference.
And would you ever have someone on both metformin and the GLP-1s?
Yeah, I do that. Sometimes if the nausea on a GLP-1, like let's say I can only get semaglutide and I have a patient with significant nausea, I'll have them take that and then metformin. I don't combine any other diabetes meds with those two because it's too far out of my specialty that I will enlist the help of endocrinology, but I'm very comfortable with metformin and the GLP-1s and also using them together.
And what dose do you aim for with metformin?
I find that once I get above 1,500 a day, people complain about stomach upset, and even at
Yeah.
1,500 milligrams a day, they're pretty unhappy, but I try to get them on the beginning, I'll tell them, "Take 500 extend to release every day, and if you don't have any stomach upset, double it within 2 weeks." And then we go from there.
So you mentioned that in your experience, patients with HS on the GLP-1 agonists, you're seeing improvement in their HS.
Undoubtedly. I mean, I have one patient I saw 2 days ago, and I know her from, I don't know, maybe I've seen her for about 8 years. I cannot believe the difference in this woman. Like, she used to have flares every day, wearing maxi pads in her armpits because she was constantly draining, never dated, never exercised, was so limited in life. She's lost 70 pounds on
Mm.
tirzepatide, and she never calls my office. I never do injections. She has no problems. She has a lot of scarring, which will
Mhm.
probably need to be surgically corrected at some point. And maybe once or twice a year, she'll say that she has soreness in one of her armpits. I mean, she's like my classic example of someone who just needed to get their insulin down, and it runs in her family. And I have other patients that are like her too.
Interesting. And in those patients, are they on a GLP-1 agonist and typical HS therapy like a biologic?
I still have a number of patients on combinations of adalimumab and tirzepatide. Most of them have gotten off of the biologic though and are just on tirzepatide as monotherapy, and they've done
Mhm.
great.
That has been my experience as well, but I have to say some of my colleagues in the HS world that has not been their experience and the data that's coming out seems to be mixed. Actually, the latest study I saw showed really modest benefit, if any. but the doses were quite low. The doses of semaglutide were quite low in that study. So I think more needs to be done. I think better studies need to be done, but certainly anecdotally, I think this provides benefit to the right patient.
And I agree. I think low doses don't do much, and I haven't been as impressed with the first GLP-1s. I think the tirzepatide is better for HS, and it does take longer and higher doses.
And would you say is the average time for you to see efficacy?
Most of my HS patients, I need to get them to the highest possible dose and then get their weight down to a BMI of less than 27, usually before I start seeing impressive response. If I have a
Oh,
thin patient with HS, I think that's a different situation. I actually do genetic testing on them. I do immunodeficiency panels, and I've had several with the JAK1 mutation, and those patients are a different category. But my obese patients with HS, they do beautifully on the GLP-1s. Well, GLP plus GIP, the tirzepatide.
mhm. I think that something important that I'll take away from your last statement is you're not seeing improvement until their BMI is below 27. That right, so that could take months. I wonder if people are giving up too quickly or if people aren't staying on them long enough because of the cost. I know that's been a barrier for some of my patients.
Yeah, it's a huge barrier. And I have a few patients where the problem is if you have someone with a BMI of 60, for instance, once your weight gets to a very high weight, it's interesting. Your body becomes more efficient. So actually, your metabolism goes down a bit. And even if you fix their BMI to a point with GLP-1s or with gastric bypass, you never quite get them all the way there. So there are cases where I've sent them for endocrinology assessment and they've needed a combination of gastric bypass plus a GLP-1 to keep their insulin down. Because even if you bring the weight down, if the insulin's still high, you're still going to have a problem. So for those patients who are very overweight, I still get them into an obesity clinic and have someone assess them to see what will get them to their best health situation.
Sounds great. Well, this has been illuminating, and I hope that our audience has gotten as much from it as I have. Do you have any parting words?
I think for HS patients, it's really important to see someone who specializes like you or someone at an academic center because I think if they go, I just see a lot of patients who go to dermatologists who see it once in a while and they're just on antibiotics endlessly. And I think there are more exciting things happening and better help on the way.
Definitely. There's a lot of hope, and the HS experts are trying to do a better job of teaching all of our colleagues how to manage HS so that, people everywhere can have access. But thank you. Today, we've talked to Dr. Bordone about insulin resistance in HS, and some key takeaways from my perspective includes the importance of testing our patients with HS for insulin resistance by checking a fasting glucose, fasting insulin to calculate their HOMA-IR score, checking their AST, ALT, lipid panels, and a platelet score in order to calculate their FIB4 score to make sure they don't have liver fibrosis. I think that is a practice changing takeaway from today's session. Thank you all for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on HS. This is Dr. Jeanette Okoye for the Medscape in Discussion podcast.
Thanks for listening to Medscape's In Discussion Hidradenitis Suppurativa podcast series with our host, Dr. Jeanette Okoye. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on hidradenitis suppurativa.